appreciate nursing management. Okay. So uh, grab it. Don't only learn for examination. Learn because you want to be a better person. Okay. Stream started. Okay. I hope you have been watching the videos. Make sure you watch it. Oh, Nico is in. Nico, I'm making you a co-host. Today, Aaron Eddie wants to join, so I don't know whether he's here. He asked me to send him the link. He was one of our mentors those days. So Aaron Eddie,
Is warmly
I don't know
welcome.
if yeah, I think he's with you in the north. He's in Tamale now.
Okay,
So
that's nice.
I can only come. Yeah,
Let's welcome
he
him
asked
and
me to send him the link.
give me
I don't
files
know
to join
if
that.
he has joined or not. Yeah. Okay. So let's share. Let's start business. Everything is on course. Right. So I'm not going to waste time today. Today, give me 2.5 to 3 hours of your time and let's finish everything. Okay. We did conflict resolution yesterday. Oh, yes. Yes. So we got to incidents reporting. Incidents reporting. Right. So let's start. Incidents reporting. As a nurse manager or as a nurse working as a manager on the unit, okay, and an incident has occurred and you have to report it. So why we are going to learn the purpose of incidents reporting, documentation principles, what should and should not be charted. Okay. So incident reporting are used to document unexpected events that could harm a patient, visitor, or staff members, and to improve patient safety and quality of care. Right. So what is the purpose of incidents reporting? Give me one second. Okay. So the purpose of incidents report. So an incident or occurrence report is a confidential document. Take note. Okay. Completed whenever an unusual event or error occurs. So what's the purpose? To promote patient safety, identify risks and trends, improve quality of care, provide information for root cause analysis, prevent future occurrences, and protect the healthcare organization legally. Okay. So the incident reports are used for patients for examples, medication errors. So if you are a nurse and there is a fall, there should be a report, an incident report on that. Okay. Yes, there's when there is a medication error, there should be an incident report. Treatment error, there should be an incident report. Needle stick injuries, you should write an incident report, especially those who work in the public health settings. Okay. Yeah, people will come for their immunizations and vaccinations, everything. I mean, you should, when there is an injury, stick injury, there should be an incident report. Equipment malfunctions, visitor injuries. Okay. There should be an incident reporting. An equipment is not working. There should be a report written on that. Okay. Yes. A patient visitor came to visit and there is an incident on the ward. It should be reported. Transfusion reactions. Then patient leaving AMA. Okay. An incident should be reported. So we have an example. The patient falls while walking to the bathroom. The nurse should assess the patient. It is the nurse's duty. Provide the necessary treatment. Notify the provider. Document the event in the medical record and complete an incident report. So this is what you should do if a patient has a fall. So you were the nurse manager. You were the nurse manager, and during the weekend, you were off. On Monday, when you came, you heard that on Sunday or Saturday, one of the patients fell, especially those in the care homes. Okay. This is what you are to assess. Who was the RN on duty? Was the patient assessed? What was the necessary treatment that was required for this patient? Was the provider out of hours or out of, yes, the out of hours provider or doctor? So you work in a care home, out of hours means, the normal working days is Monday to Friday, then 8 a.m. to 5 p.m. or 6 p.m. So night nurse, you came. Did you call 999 or the emergency line to speak with a doctor or 911? Document the event in the medical record. Was it done? Then was an incident report also done? So this is what you, the nurse manager, should also check for. Okay. So this is the pearl or the key notes. Patient's care comes first. A patient has had a fall. Take care of the patient first. Assess the patient. Give the necessary treatment first before you complete an incident report. It should be the last thing. Reporting should be the last thing. Don't go and complete incident report when a patient on blood thinners has had a fall and banged the head and he is bleeding. Okay. Yeah. So that is what you should note. Okay. That is what you should note. Okay. Right. Documentation principles. That's number 2. Documentation is a legal record of patient's care. So when you are doing your documentations, what are the principles that guides it? What are the things that you should meet, the standards you should meet? The documentation you think you are making, it should be accurate. Document facts. Okay. care workers were bathing a patient in the bathroom and the patient fell. Okay. You, the nurse, should investigate and get the accurate fact. Okay. There are some homes the care worker should write an incident report, but you, the nurse, will do your assessment, give the treatment, make sure that the documentation comes with what? Facts, not guesswork. It should be complete, include the assessment you did for the patient, the intervention. Out of the assessment, what data did you collect? There was a bruise on the head. The bruise had a measurement, measure it. There was a skin tear. There was a bone break. Okay. There was patient was vomiting or bleeding. Okay. These are the assessments you get. Vital signs assessment, it should be inside. Okay. Temperature, pulse, respiration, everything. Then interventions you did, you gave paracetamol, Tylenol. Okay. You did a wound dressing. Okay. Everything that you did, you call the ambulance to come for the patient. Patient is on blood thinners, care home patient. He has had a fall. You should call the ambulance, the emergency line, the 999 or the 911 to come for the patient to the hospital because patient is taking blood thinner. It's treated as what? A trauma case. Don't keep the patient in the care home. Okay. Otherwise, yes, you worked, but you'll be questioned. Patient's responses is very important. Then timely, chat as soon as possible after care is provided, not before care. After care is provided. Okay, patient care comes first. That's the pill. Take notes. Okay. So what are the objectives we are looking at? The documentation, it should be very objective. Describe what was observed, not personal opinions. Not I think. Okay. Then it should be legible. Ensure documentation can be easily read. Everybody can read 1,000 years. If we take that form, everybody should be able to read what you have written. Okay. And what you meant. You don't have to come and call you whilst you are on pension. You come and call you that 10 years ago or 20 years ago, this issue happened and the family wants to investigate it. They've taken it to court. So come to court and no. In your absence, people should read what you have written and understand it without calling you to explain. Okay. Then confidential. It should protect patients' privacy. Protect the documentation, should protect the patient's privacy. We know this one is self-explanatory. Then you should also use factual statements. Okay, instead of saying patient was careless, say patient found sitting on the floor beside the bed. Okay, during hourly rounding. Yes. We are not saying don't let patients fall. We are not saying incidents should not occur on the ward. Okay, but when it occurs, do what you are supposed to do. So if it wasn't documented, it wasn't done. That's it. If it wasn't documented, it wasn't done. Always documentation comes after care. Documentations after care. Documentations after care. Take notes. So if you are somebody that you think you easily forget, please, after your care, document. Okay. So what should be charted? Objective findings should be in the vital signs physical assessment, patient statement in quotation marks. Take note, patient statement in quotation marks. Example, I slept. So you ask the patient what happened. You found the patient sitting on the floor or sitting on the floor in the bathroom when you were doing your hourly checks. So you ask the patient what happened. The patient said, I slept while trying to reach the bathroom. Because it is the patient who is making this statement, it should be in this quotation marks. Very important. Yes. And you should write the way the patient said it. Then interventions performed, the patient's response, the notification of the doctor, charge nurse, or family is very important. Okay, family should know. Then the follow-up care that was done was X-ray obtained, bed alarm activated, okay, or reassessment findings observed. So all these ones you should note. So never chat incidents report completed in the patient's folder. Remember, we have the patient's folder. Nowadays, because of electronic documentations, email, electronic documentations, most of them has an incidence report in it. But those who are still using the paper chart, this is the folder of the patient. This is the folder. And this is the incidence report. That's another paper document. So you do your incidence report, the assessment. Some of them will do everything we've discussed on it. So assessment, what happened, where was the patient before the incidents, and what occurred after the incidents, the things you did for them. They will give you all. So you fill everything and a simple narrative. Okay. Did you call the ambulance? Did you give any intervention? So this is the incidence report. So once you have done this, inside the patient's folder, you need to document, but don't go and write this English. Incidence report completed. Let's say nurse's note, 12 o'clock a.m. Incidence report completed. This is just a form. Somebody can take it and throw it away. Okay. The manager can look at it and throw it away. They can shred it. 20 years time. Remember, when we discharge the patient, we archive the folder. So whatever happened to the folder, to the patient is recorded in the folder as well. So 20 years time, when we take the folder to court, where this cannot be found, but this document here will be found. So you cannot just write this English and go your way. No. Protect yourself and your future. Blame or accusations, opinions, assumptions, name of witnesses. Don't go and write anybody's name inside. Okay. Legal terms and references to be made. So you can, so with this one, let me comment on this. With this, you can write maybe initials of nurses or doctors or whatever. So when it happened, maybe RN, Ayariga, so AF, Ayariga Frimpong, AF, RN, AF was notified. Okay. So when it happens like that, they will go and look on the duty roster that on this date, which RN was on duty and what is the name of that, what is the full initial. Okay. Then they will know that, oh, this guy was on duty. And we also call him as a witness. Legal terms and reference to negligence should also be. So example, medication error occurred because the nurse was careless. This is a wrong statement. As a nurse manager, don't write this. Okay. The question is, the nurse managers, they also have their appraiser. They have a booklet. We call it nurses appraiser or staff appraiser. What do they write about you? Okay, when they are working with you. So as a nurse manager, don't go and write this against anybody's name. That medication error occurred because the nurse was careless. No, it's a wrong documentation. The correct way you should say it is that at 9 o'clock, specific time. Ordered dose of metoprolol 25 milligram per oz omitted. Provider was notified. Patient's blood pressure so and so and heart rate so and so. No adverse effect noted, or whatever you did, whatever was done. Okay. Or according to RN so and so initials. So you are a nurse. Sometimes you go to work, you are the nurse and at the same time the manager, especially night people and weekends. That is why every nurse should learn what? The management of care. Documentation errors. When you are using a paper chart, okay, then I want to see what I'm writing. I'm reading. Draw one line through the mistake. So if this is a mistake, draw one line through it like this. Don't go and do this. Okay, it's not the best, it's not the right way to correct errors. So draw one line through it. Then write into brackets or this apostrophe, mistaken entry. So let me, mistaken entry, ME. Then, comma, your initial, PB, comma, today's date, 6/25/26. Done. Okay, that is what you should do. Right. Those of you who are using electronic records, follow your hospital policy. Never delete entries. Remember, the computer guys, the IT guys, the nurse informatics, they have archive, whatever you document in the system. So when you delete, they will see. So you will think you have deleted, but for them, they are still having the information you keyed in. That is why when you are using electronic electronic record, don't enter what you think it can be. It's not correct. Okay, they have everything. If they want to check, they will see. Okay, so this is the comparison table. The chart in medical record and what you are supposed to put in incidence report. Okay, let's do some questions. A patient falls in the bathroom. Which action should the nurse perform first? Yes, sharp.
Assess patient.
Assess the patient.
Assessment. Okay. So when you get a slide, you make sure you answer it yourself. I've told you I'll not answer for you nowadays. Which patient should not appear? Which statement should not appear in the medical record?
Incidence report completed.
Incidence report completed. Okay. Which statement demonstrates objective documentation? Objective signs and symptoms. Maternal health. Objective documentation. Yes.
B.
B.
Patient found lying on the floor beside the bed.
Okay. Yes, patient found lying on the floor beside the bed. Okay. You cannot say patient was confused and careless. No. Patient intentionally refused assistance. No. All these qualifiers, these verbs, I mean, careless and all, patient caused the fall. Okay. Yeah. So that is it. Which event requires an incident report?
Patient fall without
Patient fall without injury.
Patient fall without injury. Okay. Yes. Patient fall without injury. So the golden rule to incidents reporting says care for the patient first, document objective facts, complete incidents report separately, and never mention the incident report in the medical report, that incident report completed. Okay. So let's look at chain of command. Nurse managers, you should know, and nurses should know the chain of command. When something happens on the unit, okay, or when you need any favor, there should be a command, a hierarchy you should go through. You cannot just get up and go to DDNS. The DDNS, I want holiday. Okay. You cannot just get up and go to the nurse, HR. HR, I want holidays. No, there should be a chain of command. Okay. So the nurses and the nurse managers should know this chain of command. If you want to be a nurse manager, you know everything. So keep this slide anytime if you are a nurse manager listening to me, keep this slide anytime you are having any doubt. Go and read it. Okay, what should I do? What should I do? What should I do? Okay, a short pen is better than a long pen. So when to activate the chain of command, this is what we are going to look at. Then also we also look at resolving patient safety concerns, then escalation procedures. So this chain of command, or COC, is a line of authority. Line of authority used, okay, to address patients' care concerns when immediate problems cannot be resolved at the bedside. COC is mostly used in what? Job interviews as well. This is what I was looking for yesterday. Okay. A problem has happened on the ward. People who go on nurses, you will get a job. Definitely after passing NCLEX, you will get a job. Be ready for a question from this topic when you are doing your online interview, okay, or face-to-face interview. Okay. So when to activate chain of command? The chain of command is used when the patient's safety is threatened and the healthcare provider or immediate supervisor fails to respond appropriately. Okay. Yes. So let's look at some situations. Change in patient's condition. The nurse didn't do anything about it. We have to activate the chain of command. Somebody must start it. Provider does not return calls. Activate it, because patient safety is at risk. Unsafe orders from the doctor. That is why you have to learn your pharmacology. Okay. Yes. Chain of command. Conflict among health providers affecting care. Patient is in safety is at risk. Activate chain of command. Concerns about impaired staff members. Okay. Somebody is growing. He is getting arthritis. He is a healthcare assistant, or he has a back pain. Okay. He or she knows that if they report it, then we can reduce their contract hours according to law. But if your contract hours is reduced, how are you going to pay your bills? How are you going to take care of your children? So they will keep quiet and will be enduring. We are doing personal care, changing patients' diapers and everything. We have 70 or 50 residents on the floor, 3 carers. We are taking care of all these people. This person is having what? Issues, pain, back pain, back pain, back pain. Because of that, the work is not moving fast. Okay. There is a concern about staff impairment. So is it good for you to report the staff to the nurse manager or what? So that a health assessment will be done for this patient, for this staff, and the necessary steps taken. Then ethical issues. Okay. Ethical issues. Somebody doesn't wear uniform or the prescribed uniform to work. Okay, it is causing issues. The ethics of nursing, you should dress appropriately, but you're not dressing appropriately to work. Every country has what? Their own ethical issues, okay, about their profession. The nurses in the United States, they even come to work with cosmetics, okay, and enjoying life. But some countries, you can't do that. There are some countries you even have to cover your head and everything. But it's not like that. So every nursing state has their own ethics. So the nurse manager must know. Inadequate staffing, threatening patient safety. We always endure. Okay. In this regard, you have to what? Safeguard the shift. In UK, we call it safeguarding. You have to safeguard all the staff who came to work because of short staff. So that when something happens, they will not blame anyone. They will blame the company. They will blame yes, that is what we call safeguarding. Okay. Right. So example, a patient develops chest pain and ST elevation. Okay. The nurse notifies the provider, but no response is received after repeated attempts. Action: escalate concerns through the chain of command. Okay. The nurse's duty is to protect the patient. Okay. So always the patient is your property. You are the advocate. So protect it. Don't protect the hierarchy. Don't protect the doctor. Don't protect your colleague. Protect the patient's safety. That is it. So let's look at a typical chain of command in most hospitals. We are nurses, so I'll start from nursing. Okay, the nursing staff, when we go to work, among the nurses, one will be taken as a charge nurse. Above the charge nurse, there is a nurse manager or supervisor. Okay. Then above the nursing supervisor, we have the director of nursing. In Ghana, we call it what? DDNS. Okay. Then we have the chief nursing officer also there, who is also in the hospital. But in Ghana, the chief nursing officer is sitting at the health ministries. Okay. Every hospital has a chief nursing officer. Then the chief medical officer and the hospital administrator. This person has a rank or a qualification in business or health administration. Okay, yes, and it goes like that. Okay, so all these nursing staff should be on duty within the week. On weekends, this one will come. This one will not come. Director will be on off. The nurse manager will be off. So it will be left with the charge nurse and the staff nurse. Okay, yes. The charge nurse should be on duty, whether night or day. So you are the charge nurse. You serve as a manager and serve as everything. The hospital administration will close on weekends and night. So you are everything. Okay. Now, this is where the interview questions come. Resolving patient safety concerns. The nurse must recognize the problem. So they will ask you went to work, so and so happened. As a nurse, what will you do? But then they will give it to you. Interview question number 1. Abi, you have written in your CV that you are a good manager, you are this, you are that. Okay. You ask you management question. 2 patients are fighting on your shift, or a visitor and another staff, or 2 nurses are fighting, 2 colleagues are fighting. What are you going to do? The nurse, you must recognize the problem. Okay. Identify any threats to patient safety. You communicate clearly using the S bar. you notify the provider in cases of any patient care issues. Okay. Document attempts made when you were contacting the doctor. I called the doctor at so and so 12. It is now 11:46 here. So 11:46, I called the doctor. The doctor didn't answer. The next time I call, I know the time and the date, the number of times. Okay. Escalate if necessary. So from this part to this part, you, the nurse, you are going to try to solve the problem within your strength or within your absorptive capacity. If it is beyond your strength, okay, or beyond your scope, or if solution is not met, then you escalate, take it to another higher level. Okay, move to the next level if the concern is unreserved and they are expecting you to mention this English, especially when you are doing job interviews. If you go and say any rubbish thing, they will fail you. You will be talking, they are smiling, but after the interview, they will say, unfortunate, we are sorry. And this time around, we moved on with other colleagues who did well. Okay. Continue advocating until the patient receives appropriate care. Continue advocating for them. Okay. A typical example, a doctor wrote potassium chloride order medication. Yes, IV. Okay. But he wrote push it. Do we push potassium chloride? Did you do yes or no?
No, sir, we don't.
Say no, we
No.
don't.
So what will happen if you push potassium? What will happen?
The client is possibly like cardiac.
I can't hear you.
But it can
Yes, the
cause
patient
arrhythmias.
arrhythmia. Good. Yes, so you know this. The doctor maybe mistakenly wrote that. Okay. So since IV push potassium is unsafe, are you going to give? No. So you have identified the problem. Then you communicate with the doctor using your S bar. You know it. This one, the patient does not have a problem. So the current situation will be the error. The error. Okay. The background, you still talk about, oh, doctor, this patient on room this who came is also and so I saw that you ordered for potassium. Okay. But the current issue is that I realized you ordered IV push, which I think is unsafe. So I wanted to clarify if maybe by mistake you wrote it or what. So you clarify the order. If it says, oh, give it. I mean, potassium is too low, 1.8, 2.0. Give it, push. Or open the fluid, let it flow. This guy. Then you what? If unresolved, you notify the charge nurse that this is what is going on. It's beyond me. So come in. So you escalate the chain of command. That is how we do it. Okay. Never carry out any unsafe order. You'll be in trouble. Okay. So how do we escalate? Now you have reached the level that it is above you. You want to take it to the higher level. How do you do that? After recognizing the concern, example, patient's blood pressure has dropped to 78/40. You have done everything. Reverse Trendelenburg, patient's leg up, head down. You have IV fluid going. I mean, you've checked, you've done all the assessment, done all the vital signs. Still, blood pressure is dropping. Let me take you to the next level, the doctor. So you still call the doctor again with your S bar. Okay. Yes. So who can say an S? Who can give me an example of S bar here? Don't look at this one. Use your own English to develop an S bar for this problem. Don't look at this one.
Patient is currently agitated.
Your voice is down, Chichubu. I don't know where you are hiding.
Sir,
Because
I
me,
said
my
patient
volume.
is currently agitated, pacing up and down.
I can't hear you. Please, can you hear him? Was me. I think he has
Yes, I
even
said,
muted himself.
Can you hear me
I said
now?
patient is agitated. Okay, yes, talk.
Yeah. So I said patient is agitating, pacing up and down.
With this blood pressure,
Oh no, so I
look
thought
at this
you.
example. Call the doctor. Don't
Oh,
look
okay.
at this. Reframe your own.
Okay. Hello, doctor. Good evening. My name is Nicholas, a staff nurse at the MedSurg Unit 4.
Okay.
I'm calling
Okay.
you. I'm calling you. I'm calling you because of Mr. Paul, who currently has a very low blood pressure of 78/40.
Okay. You have got to check on this. Mhm.
Mr. Paul was admitted 3 days ago, and he has been stable since. He has been put on antihypertensives, the following antihypertensives, enalapril and furosemide. On assessment, he seemed to be sweating profusely, and he complains of severe headache. He looks pale, and his capillary flow is greater than 3 seconds.
Okay.
I will recommend you make orders for IV fluids to be infused to increase his blood pressure now. And I will also recommend you come and assess him further. Thank you.
So what did you leave? You left background. You said patient was admitted 3 days ago. With what? You ended there, then you jumped to assessment.
Maybe it's a non-explicit client or a
Okay.
non-explicit.
Yes. Okay. Patient was admitted. What was the background of the patient? Okay. Patient was admitted. So in this situation, he came with sepsis. That was the background, the history. Okay. But currently, he has a new situation. He has a new problem. And this is it. Okay. And you, the nurse, you have done your assessment, and this is what you saw, as you mentioned perfectly, but you used the English sim. Sim means what? Because your communication should be fact. But you said patient seems to be sweating profusely. Is that a guesswork, or you are talking fact?
Assumption.
I said sin.
Sin. Oh, sin. Okay,
Sin.
good.
Yes,
Then you are right.
patient.
Perfect. Then you are right. Okay. Then recommendation to JJ. You know what you are doing. Okay. So next time you're fishing there. If you do it this way, you see within short time, you have done a report. You have spoken to the doctor with all informations rather than going to write plenty things. Okay. It won't work. Okay. Repeat notification if needed. So we are moving on. Okay. So notify the charge nurse and repage provider, record them. Then you move up to the chain of command, escalate to this is a unit manager. You know the chain of command now. The nursing supervisor, medical director, administrator. Go through that channel. Then document whatever has happened. Time of notification, person notified, patient assessment, interventions performed and all patient response. So you see the telephones on the ward that we used to call the doctor. Some of them has what like how a directory or so that the time you call somebody it will record beside like our phones. So sometimes if you forget, you go to that telephone you used, then you look at the history. It will tell you at this time you call this doctor. So you see the time there. If maybe you are so super busy that you have to do other things before you document. Okay. Never document doctor ignored me. Instead said provider paged or call at 14:30 and again at 14:45, 15 minutes after. No response received. Charge net notify at 14:50. Simple. You have done your work. You don't have time for anybody. Okay. So these are the comparison table, whatever you are supposed to do, the situations and the actions you are supposed to do. When you get your slide, you already have it. So let's do some questions. A nurse contacts the physician twice about a deteriorating patient, but receives no response. What should the nurse do next? Yes.
Activate the chain of
Chain
command.
of command.
Perfect.
C.
Good. So you will make this in your exams. Which situation requires use of chain of command? All these situations, which one will you activate the chain of command?
Physician prescribes potassium chloride IV push. B.
Good. Simple questions for you. Which statement best describes the nurse's responsibility in chain of command?
Patient's advocacy takes
Me.
priority over hierarchy.
Good. Okay. So the golden rule is that when patients' risk, safety is at risk and concerns are not addressed, the nurse must continue up the chain of command until appropriate action is taken. Patient advocacy always comes first. Okay, thank you. So this is where we were supposed to end yesterday, but we ended early. Let's start today's chapter sharp. So today, as a nurse manager, you can be home. The nurse is a nurse everywhere. Okay, they can call you. You work at the ER or wherever. They can call you. You are part of the rapid response team. The nurse manager, anytime there is a rapid response, the nurse manager must be there. Take notes. The nurse manager, somebody has sounded or pressed on the code blue alarm. You are in your office. You didn't come. You are doomed. Okay. The DDNS, whatever, everybody should come because you are a nurse manager. Okay. There is an emergency. There is a disaster, fire. It has burned a lot of people. A building has collapsed. A lot of people are in the nurse will also be taken as a rapid response team. So if Tichubu is taken to when there was stadium disaster some years ago in Ghana, the hospitals in Accra, the nurses were sent there to go and help rescue. So when you go in disaster, you should know what and what to do. What is the duty of the nurse there? The nurse is there as a triage personnel. Okay, as a triage personnel. Remember, this is a disaster triage. Not plenty patients that has come to OPD that you are doing triaging. Okay, this is a disaster. Yes, there is flood. A lot of people has been killed by the water. Okay, you have to go and do your triage. There is disaster. So I'm going to show you how to do triage when it comes to disaster. You can be in church and the building will collapse. You can be in church and people will attack you. Your children can go to school and people will attack them in that school. That is disaster. They will call, the nurse must come. There is a car accident, about 5 cars, it has crashed. The trailer has crashed a lot of people. Some are dead, some are screaming, the nurse will go. So when you go, as you are going, maybe your DDNS did not follow you, but you should note that you are a nurse manager there. So the little resources they have given you, little bandage, cotton wool, spirit, sutures, whatever, POP, whatever that they've given you, glad they stop that. When I clear, then you write. Use it on the one you think will survive, not the one you think is going to die. Or the one, not even think, the one the assessment tool says this guy is going to die. Forget about him. But this one, okay. So note the difference. We have a disaster environment, and we have hospital setting. Normal patients coming to ER or the OPD or whatever, okay, or you are working on the ward. Yes, these two environments, the nurse must still prioritize. So they can give you a question in NCLEX or wherever, whichever exam you are writing, and they will tell you the setting. You should know the approach to do. When there is a disaster, we are going to do disaster triaging. We are going to fish out for people who will survive. Okay, we are going to fish out for people who will what? Survive. We are not going to look for people who are dying. Okay, we are not going to look for these people. We are going to look for people who will survive. So who are those who are walking? Go here. Immediately a patient can walk, talk, and do a mental assessment, after everything. Green, stand here. Okay, I will not waste my resources on you. You are surviving. Okay, let me go. Next one, blue or red. So red, go green, black. That's it. Black people, you are dying. Dying people are black. Respiratory status, you check. We have is it TMR or TRP? Yes, TRP also. Okay, you are dying. You are black. Once the checklist put you in black, I don't have to even add cotton wool to your skin. We are under disaster management. Okay, in hospital settings, you have 30 patients on the floor, or as a med-surg nurse, you have 6 or 7 patients taken care of. All of them are stable. You are the one who is dying, is the one you prioritize. So you see the difference. When we come to the hospital setting, where the situation happening is not disaster, we are looking for what? People who are dying, prioritize care. Okay, if the hospital floor, let's say 3 floors, and it crashes, med-surg unit, and the floor breaks, the building breaks, and people are dying, the situation has changed to disaster. So I am not going to look for the dying patient. I'm going to look for the stable and surviving patients. That's it. So always take notes. You are OPD nurse. A lot of patients are the OPD. You are triaging for what? It is not disaster. So you are triaging for the dying, the unstable. But the OPD building crashed whilst people were there. The thing has changed from normal medical attendance to a disaster system. So I will start looking for those who survived to use my resource on. So nurse manager, you should know these two differences. A lot of people say, I got triage question. Why is it that I failed the licensure? I failed the NCLEX. because you didn't know how to manage certain things. So I'm opening your eyes today. Let's start. Always a nurse. You should always use what we call the start triage when you get to disaster scene. Car accident, a lot of people are injured. You are going, start. Oh, they use the acronym START. Start triage. Start triage. Okay, start triage. Start. The nurse, whether you are a student nurse, whether you are this thing I'm teaching you, go and teach it to your church members, teach it to everybody. Start triage. So once you start, the next thing is your color coding. Okay, your mind has started, but you should know your color coding and how to code them, code the people, human beings. Okay, in disaster management, coding, then emergency response. When I did my color coding, which of them are surviving? Okay, emergency response, come for them. Ambulance, come for them. Take them to hospital. Take them to us. This guy is in black. All blacks, you don't have to waste your time, fuel everything on them. Okay, then we have what bioterrorism. So these are the things you are going to look at for now. Okay. So the NCLES spell, red, is immediate. Immediate, red. So let me show you the trick. You know, we have red, yellow, green, and black. Okay, so red, you always use, this is my own trick. Okay, you always use what? The first letters. We those in Ghana, we are lucky because our colors are red, yellow, green, black. Okay, yes. So first letters, I have come to emergency scene, car accident, red, yellow, green, black. But only yellow, you use the W, the last word. So red, the R means they are in danger, so they must be seen right now. The R, right now. The yellow, yes, they are a bit stable. Okay, so they will wait. They will wait or delay. That W, the last W of yellow, will always wait. Let it be in your mind. This thing, you don't have to go and read it again. Okay, because maybe after this seminar, after today, you are going to meet a situation where you apply. The green are those who are walking. They are going. So green, when you get to the traffic light, you see green, go. All cars will move. So which of the patients are walking? They are going. They are talking. Everything is normal. They are stable. So going, I mean, you push them all to green. Okay, they are going. Even if they are complaining of pain meds, forget about them. Once you are walking, you are in green. And black. Black is beyond help. Beyond help. B for black. So please, I'm sorry. Your problem you are having, I have little resources. As a manager, I can't use it on you. You are beyond help. If I want to use, I'll use all the resources on you. So you will not survive. Okay. So when you meet a patient who is dying, when we say a patient is not breathing or is not having a pulse, okay, it's not breathing or it's not having a pulse, you start your CPR. Okay. So why is it that there are some people we are saying they are beyond help? So let us put them in black. Let us allow them to die. Okay. So you start with your breathing. Okay. So is the patient breathing? Yes. Any patient you get to, is the patient breathing? That's the first thing. Yes or no? If it is yes, okay, what is the respiration rate? Is it below 30 or above 30? If it is above 30, automatically they are red. Ambulance, come for him. Okay, I'll give you the chart. Don't worry. If it is below 30, you move. Okay, below 30, what is the pulse? Is he having a pulse? Yes, he has a pulse. Okay, yellow. But this thing is so simple. Always breathing. I met Tichubu. Car has knocked Tichubu down. Tichubu, is Tichubu breathing? Yes, he's breathing. Okay. And you have less than 30 seconds. Oh, yes, no, it's 30 to 60 seconds. Every patient, triaging. Car has not, God forbid. So, is the Tichubu breathing? Yes. What is the respiration rate? Okay. Respiration rate below 30. Is Tichubu having a pulse? Yes. Okay, Tichubu is yellow. I don't have to worry myself because breathing and circulation is intact. Tichubu is breathing. Respiration rate is above 30 in every 1 minute. Tichubu automatically red. Where is ambulance? Take this guy to the nearest emergency unit. Let's intubate. Let's secure the airway. So let's go down. Disaster triage is a rapid sorting of patients during mass casualty incidents to prioritize cases when resources are limited. Okay, the goal here is to what? Save the greatest number of lives, not to save family members and friends. Okay, yes. Treat most likely to survive with immediate intervention. So the tip or the pearl says that in disaster, priority is based on survivability. In disaster, survivor or priority is based on survivability, not necessarily on who is the sickest. Take notes. Okay. Okay, so start triage. Emergency has come. We have rang the bell, start triage. So simple triage and rapid treatment. That is the acronym. Simple as triage and rapid treatment. Every patient has between 30 to 60 seconds. So Tichubu is our head. All of us are following Tichubu. We are student nurses. So Tichubu has 30 to 60 seconds, every patient, to make a decision. 30 to 60 seconds. Okay, are you breathing? So, are you breathing? Yes. If patient is breathing, Tichubu will leave because we are following Tichubu. He is the head of triage. We are following. Okay, another person, Victor is below, so Tichubu will command. Check the respiratory rate. If it is above 30, move to red. If it is below, check the pulse. Is he having a pulse? If pulse, yellow, sharp. Next patient. So in a space of 10 minutes, you can look after over 20 patients. That is what we call start triage. Patient is not breathing. You open the airway, you do all your airway massage. Still, patient is not breathing. I've stayed with you for 60 seconds. I'm not seeing any breathing. Black. Oh yeah, let's go. Jump this guy. Okay. Patient is not breathing. I'll look at your chest. I'll feel your nose, your nose. There is no carbon dioxide coming out. Okay, you are not breathing. I'm looking at your chest. There is no chest rise and fall. Let me open your airway. There are some people, when you open their airway, they begin to breathe. So quickly, Tichubu will make a command. This guy is breathing. The next person, come and stand with him and check what? The respiration rate. Respiration rate above 30. You know the algorithm already. Above 30, red. Below 30, assess pulse. If pulse is there, yellow. Let's move on. Okay. So that is it. That is disaster trial. So we do respiration, perfusion, mental status. Respiration, perfusion, mental status. And there another team too will be assessing our mental status. You know how to assess mental status. We don't do this thing here. How do we call this assessment tool? We use AFPU in emergency situation, or if you want to work so fast, use AFPU for mental status assessment. Alert, responsiveness, verbal or responsiveness, and whatever. Okay. Don't go and use DCS. Yes, this is what I wanted to say. We don't use DCS for emergency situation. DCS, patient lying on the ward or patient who has come to the ER. We are taking care of this patient. We are not in a rush to make any clinical decision. Let me take our time to use DCS to assess what the mental status or the responsiveness of this patient. But in emergency situation where we have only 60 seconds, mental status assessment, AFPU, sharp, remove. Okay, so this is the chart. If you get it, you can even take it and put it on your phone. I intentionally. So we come, disaster starts. Teacher is our leader. Every patient has 60 seconds. Okay, so let's use RPM, respiration, perfusion, mental status, respiration, perfusion, move on to the next patient quickly. Life-threatening problems first. Okay, so I come to you. Can the patient walk? Yes, green. Okay, remove. Whether you are having, whether the car has broken your bone or whatever, you are walking. Your hand is broken. You are walking. So whatever complaint, once you are walking, green. Okay, is the patient walking? No. Okay, let's go. Let's use the RPM. Is he breathing? Okay, is he breathing? Yes. Remove. If not breathing, open the airway. So you do your head tilt and tilt. You raise the head tilt, the jaw thrust and the chin lift. You've opened. Is the patient breathing? Yes. Okay. If not, we've done airway maneuver. If not, black. We don't have time for you. Let's move on. Patient breathing. Check the respiratory rate. Is it more than 30? Red. Okay. Then you come here. RPM. If below 30, you move. Check the pulse. We are checking for perfusion. Is there a pulse? Yes. Okay. Or no pulse, move to red. So there is a game of circulation breathing. Can you walk? Circulation breathing. And the last thing we do, so after you do everything, then the last thing you do, that those people the tube will push to us. Okay, some will be checking the respiratory rate, some will be checking the pulse, some will be checking the mental status. Okay, so all this respiration and circulation and all this, if it is above normal, we push to red. We call them unstable patients. They will go. They are not dying because their airway is intact. Okay, the guy who can follow simple commands, we move to yellow. Okay, yes. So this is it. Red people are life-threatening injuries, requires immediate treatment and transport. Yellow, serious illness, treatment can be delayed. Green, they walk. Yes, they have a wound, but they are walking. Minimal treatment needed. Expectant, black, death. Okay, diseased or injuries so severe that survival is unlikely. Yes. So after we sort all these ones, those who are dead or those who did not qualify to move to the next level, we push them in black. When everything is calm, we will now go and assess them again. Okay. Among the dead, there's still some people who, so you remember the disaster management. Some people were put the stadium disaster in Ghana. Some people were taken to the mortuary, but they were not put in fridge. 3 days, 2 days, some of them got up. Okay. Yes. When we were doing the triaging, we put them in black, took them to mortuary. Okay. But the mortuary guys did not put them in fridge. They just put all this formalin and all these preservatives on them. Then 2-3 days, some people got up and they are alive till today. Okay. Yes, that is why when somebody dies, you don't have to quickly put the person in fridge. Okay. Can the patient walk? Ask. So if you can walk, please move to this area, green. We don't have time for you. Okay. You have a minor issue. Yes. So patients who walk are classified as green. Then respiration. Are you breathing? Patient is not breathing. The fact that patient is not breathing does not mean push him to black. Assess the airway. Open, you do your airway maneuvers. You open head, chin lift, jaw thrust, or head, you move the head back. You have opened the airway. Still, patient is not breathing. 60 seconds, patient is not breathing. Black, you don't have time for you. But if patient starts breathing, you check respiration rate. Is it above 30? Yes, red. So the red guys will come for him. Then breathing. If patient is breathing less than 30, move to what? Perfusion. Somebody should check the heart rate, the pulse. We are nurses, we know how to check pulse. Okay, yes. So you check all this, your capillary refill and all those stuffs. If no pulse and capillary refill is still above red, so there is no pulse, patient is unstable, okay, by his breathing. So red. So the red team will know what to do. Okay. If normal, if you check the pulse and it's normal, yes, and there is pulse and capillary for everything is there. Okay. You go on to what? The mental status, the central nervous system, the mental status. Can the patient follow commands? No, red is unstable. Can the patient follow commands? Yes. Okay. So you are breathing, you are having a normal pulse. The only problem is your mental status that you are having. Okay. So yes, we move you to yellow. We are going to delay your care. Okay. So these are the color coding. So red people can have severe bleeding, airway obstruction, or shock by their breathing. Yellow, you see people with their bones broken, they'll be crying, pain med, pain med, pain med. Forget about them. Do your assessment. Abdominal injury without shock. Okay. Green, they are having minor cut sprains, somebody, the head is swollen and like a coin swelling, abrasions on the skin. I mean, those people, okay. Then black, massive head trauma, no breathing, after airway repositioning, everything maneuvers, you are still not surviving. So I have highlighted this for you. Red, always the first letter, red, right now, work on him. Yellow, wait. Green, go. Black, beyond help. We don't have time for you. Okay. So emergency response. Emergency response. And the nurse manager should ensure everybody is in their PPEs. Okay. So we did PPE yesterday. So the nurse manager must ensure everybody don PPE well, because the blood and body fluids are always considered infectious. Whether you know lab results or not, always is infectious. Then you activate the emergency plan. Okay, so we have the EMS ambulance activation, we have the incident command system, we have the hospital disaster code. Somebody will press the alarm. Wow, 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 wow. Somebody in advanced countries, sometimes an alarm will blow on everybody's phone. Okay. Yes. An alarm will blow. Like they say there is a storm coming in US and UK and all these advanced countries. Once you enter the country and you buy their SIM card, it is connected to the emergency station of the country. So a storm is coming. They'll activate the code that everybody should be careful, stay home, don't go anywhere. A storm is coming. Is there a storm? Is there wind, the fire, or whatever? So everybody will get alert, and your phone will blow alarm. Okay, your phone will blow a very loud alarm. That is, everybody in the country will get an alert. Then, so wrap up always your start triage. So life-saving interventions, open airway, control severe bleeding, tourniquet if needed. So those in red, I mean, they will be taking care of all these guys. Patient positioning, avoid lengthy treatments, then transporting. The ambulance guys will be transporting them to hospital. Okay. Then documentation. When they bring the red guys and the yellow guys to the hospital, the OPD or the emergency people will now be looking for which of them has a severe issue, or they will look at the tags, the triage tagging, the identification or the disaster logs. Okay, yes. So whilst they are taking care of them, then they are doing the documentations. It's a nice experience. Sometimes if you experience it, you enjoy. Okay, yes. So this is an incident command system. It's a standardized emergency management structure that coordinates resources, assign leadership roles, and improve communication and reduce confusion. Some nurses will collapse when there is trauma. Yes, student nurses will come to the emergency room. They will bring a patient with severe trauma, level 1. The nurse will be standing there and they will collapse. Okay, so there should be an incident command system to check that health workers taking care of this patient are not confused. Okay, they are not panicking. So the people will assign the roles, the leadership roles to us. You take care. Somebody should take IV, somebody should do documentation, somebody should do this, like the way we do code blue. Okay. So a lot of disasters can happen in life: flood, hurricane, tornado, earthquakes, fires. These are hot natural disasters. Human beings can also create disaster. We call it explosion, bomb, terrorism, chemical spillage, okay, mass shooting, radiation incidents. Radiation incidents. So you know all these things. Okay. Then we have what we call bioterrorism. Yes, this is also a human disaster. It is an intentional release of biological agents to cause illness or kill human beings. Yes, some people do it. Bioterrorism. Yes, people can release chemicals into the air, let people breathe and get disease. Okay, so whilst they are getting diseases, then we will bring a solution to solve it and we get money. Okay, yes, so some of the conditions that came, bioterrorism, by investigations, anthrax was part. Okay, anthrax was part of the category, the CDC categories. Okay, smallpox, when it started, a lot of people got it in the world. Okay, plagues. Plagues came, fever, cough, hemoptysis. People are getting respiratory droplet issues like pneumonia issues. Botulism, okay, also came. Then tularemia also came. Then viral hemorrhagic fevers, Ebola, and all those stuffs. They were all disasters. That's okay. So what is the nurse's responsibility during bioterrorism when it happens in your community? Recognize unusual disaster clusters. Use appropriate isolation precautions. Don't panic. Notify infection prevention and public health authorities promptly, especially COVID when it came. When you see any COVID patient, okay, notify the healthcare guys, the public health guys. They will come and take sample quickly, quarantine the patient. Protect yourself with PPE. Don't panic. Assist with decontamination when indicated, and provide psychological support to the patients and their families. Okay, yeah. So a mother brought the child to the hospital and was having COVID during those heated times. Okay, you have to quarantine the mother and the child anxiety all over. Family is worried. Husband is worried. So the nurse will be an advocate, talking to them, encouraging them. Okay. So these are the pills. Start pills for triaging, walking patient, respiration, cannot follow commands, red. So unstable, red, unstable, red. Okay. During disaster, provide the greatest good for the greatest number. And in triage, perform only rapid life-saving interventions before moving to the next patient. Okay, let's do some questions. During a mass casualty, a patient is walking with a minor arm laceration. Which triage category should the nurse assign?
Green.
Go.
Green.
Go.
Okay, good. A patient has a respiratory rate of 36 per minute after a building collapse. According to start triage, what color should the patient receive?
Red.
Red.
Okay, perfect. An unconscious patient is not breathing. The nurse opens the airway, but the patient remains apneic. According to start triage, what is the correct classification?
Beyond treatment. Black.
Black.
Okay. Right. So let's do case managers. There is a profession in nursing or a specialty in nursing called case manager, who also ensures continuity of care. Remember, we have management of nursing care, which can be done by all nurses, whether you are a nurse, a student, whatever. Then we have case managers, which is a specialty. Okay. They also ensure continuity of care. If people, they come to hospital, whatever, in the community. So if Tichubu comes to US and wants to get a lot of money and wants to, you go and specialize case manager. When you come to work, you are sitting at your office. So you go to patient by patient when admissions come or when patients come to the ER. Okay, you link the patient to, their comfort, their shelter, their everything. So you are coordinating those activities. You are a case manager. Okay. Yes. So case manager, they will assign. We have plenty case managers. There is no hospital that we have only one case manager. But there are some hospitals, even Message alone has over 50 or 100 beds. How can one case manager? So it is one of the lucrative jobs for nurses in the US. Okay, yes. So what is the work of the case manager? We are going to look at discharge planning because they will start the discharge planning. Home care. Yes. We still need, patient is well, but he still need nursing care. Should we take the patient to home care home, rehab, hospice, or what? Or palliative, depending on the condition of the patient. Some are dying, hospice. Some are having cancer and all this pain management, palliative. Some are going to. So the case manager will talk to the doctors and the prescribers and all the paramedic team and make a decision. This patient should go here. This one, they should allow them to go home. Let's refer to the public health nurses in the community. So that is the work of the children when he comes to US. Okay. So we are going to learn the purpose of case management. Describe effective discharge planning. Discuss the role of home health care and differentiate rehab, palliative care, and hospice. There's a lot of case managers get problems here. Okay. You don't know which patient should go where. Okay. Apply these concepts to NCLEX style priority questions. Go to mommy. Okay. So what is case management? It's a collaborative process that coordinates healthcare services, ensure patient receives appropriate, safe, cost-effective, and continuous care. Take note. It coordinates healthcare services. They don't coordinate the health workers, but the services. Tichubu, your job. So a patient has come to the hospital. Okay, what are the services in the hospital? X-ray. We have CT scan, physio. Okay, so yes, on the ward, the RN is taking care of this patient, but the case manager is sitting at his office watching whatever is going on. So he will coordinate. Okay, patient is going to this. Okay, patient is going here. They coordinate the services. Okay, patient has been discharged. Where should we take the patient? Patient needs services of palliative care. So let's take the patient to a palliative care unit in town. So there is a service he's going to assess. Case manager, okay, coordinate, make calls. I'm bringing this so and so patient to you for this so and so. Okay. Patient has been admitted from day one. Case manager will start the discharge planning from day one. Okay. A patient has come in town. He is homeless. In US is very, very common. You can be the least thing you are homeless. So somebody has come. He is homeless. So he came with what? Maybe hypertension, severe hypertension. He's sleeping on the street. He's getting frostbite. So severe winter. Somebody is homeless. They have walked to the ER. Case manager. The patient is going to be discharged. Should we allow the patient to go home? Or we should take the patient to a care home? Okay. A patient is having drug abuse, substance abuse. Let's take the patient to rehab. For the case manager, you work there. So I know Teachubu will like this work. Yeah.
You know me, Papa.
So your goal is to improve patient outcomes. Okay. Reduce hospital readmission. Or the patient who is homeless, if you allow the patient to go homeless, they will come back the next moment. Okay. Coordinate healthcare services, promote patient independence, and ensure continuity of care. So who is a case manager? Which people qualify by the universities to be allowed to specialize as case managers? Yes, Richmond. Your hand is up. Do you want to talk? Okay. So if you are not an RN, you can't do case manager. If you are not a social worker, you can't specialize to become a case manager. You are not, there are some people, they are doing, yes, they are case managers. I mean, some hospitals will appoint you. You have not gone to school, but they have appointed you case manager. If you want to specialize, you are already doing it. So why not? We will allow you to do. Okay. Yes. So the next case managers, what do? They collaborate with all these health workers. Home health care, insurance providers, dietitians, pharmacists, speech therapists, occupational, plenty. Think about any health worker you know. Case manager knows them. They have their numbers. The court case managers is 2 years course. Okay, yeah. They it's a 2 years course. It's online, so you can even stay home and do. So yeah. So they coordinate with all these people. They coordinate with family members. Somebody has come to the hospital that the family is abusing them. Case manager, will you allow the patient to be discharged to the home again? No. Police must be involved. to investigate what is actually going on in the house. Social workers must be involved. Is the patient a minor below 18 years? So all these ones. So case manager, you don't rest like that too. There's that you don't do bedside nursing. So okay, continuity of care. So the case manager ensuring the comfortability of the patient must also ensure what? Continuity of care. Teachubu referred the patient from the hospital to a rehab center. Okay. In the rehab center, is the care that this guy was brought to receive? Is he receiving it? A patient walked to the ER, case manager has made a decision that patient should be taken to the ICU. Okay, for ICU care. It's not every patient that is fit for ICU. So the reason why the patient was brought to the ICU, are they receiving it? The case manager must also inspect that is being done. So continuity of care is the seamless coordination of health care. This one not services. So health care as patient transition between different settings. Okay, so a patient will be taken, Teachubu will send patient from hospital to care home or his home. It's either care home or home care. Okay, patient will be brought from hospital to rehab facility. Patient from hospital to skilled nursing facility, nursing home. So that is what you should know. Patient will be sent from hospital to hospice for comfort care. Okay, yes. There are some patients, they are dying. The family doesn't want them to die, and the hospital too doesn't have bed. So what do we do? Ayariga will build a big hospice unit that people can come and die easily, okay, and simple, and we'll be getting money. So Teachubu will coordinate with Ayariga. Please, I have some patients, I want to bring them. Okay. Then the benefits, it prevents medication errors. Reduce complication. Yes, it must ensure, are they receiving the care? Continuity of care. Ensure proper care is given to them. Okay, so when you inspect the care that is being given to them, reduces complication, improves recovery, decreases hospital readmission, and enhance what? Patient satisfaction. So whilst we are doing all these things, the nurses will give the care, they must document. So when they are documenting, some of them will make mistakes. So the nurse health informatics, who is also a specialist nurse, will come and inspect. Ayariga said he has opened a hospice care. He is providing hospice care. So all the care he is providing, is he documenting it in the patient's record? So the nurse informatics will come and inspect what type of documentation are they doing. The hospital everywhere. Okay, so these are the things. It's a coordination work. Now let's look at discharge. The case manager starts the discharge planning from day one. Okay, it begins on admission, not on the day of discharge. So why do we have to begin on admission? Promote safe recovery, prevent complication, prevent readmission, improve self-care. Yes, so you have to, every patient, you have to plan their discharge. So the nurse, what is your role as a manager? You assess patients. Patient is going to be discharged. Make sure proper assessment goes in. Is he fit to be what? Discharged. What is the physical condition of the patient? What is the mental status? The mobility of the patient. Can they walk by themselves, or they are going to give them a mobility aid, a walker, a wheelchair, or whatever? Okay. Ability to perform activities of daily living. Can they do it or not? Who is leaving home to help them to bath, brush, eat, cook? Okay, can we book a care package? So let's contact what? Victor has opened an agency, a locum agency. They are doing home care. Let us contact. So Tichubu is the case manager. Contact Victor. Victor, can you send some of your workers to this person's home? He doesn't want to go to care home, but we want to send workers there. They will go and help him bath. So some will go in the morning, help him bath. Some will go in the afternoon, help him eat. Some will go in the night, sleep with the patient till morning to help with activities of daily living. Yes, Tina, your hand is up.
Hello, sir. Good evening. Sir,
Evening.
please, with regards to the hospice care, can there be an instance where the client will be taken to that place and later on the client will be okay, like the client will
Right.
not die? Yeah.
Yeah, oh, it happens a lot. There are some conditions when you get it will be like you are dying, but later, your body will survive. So, oh, it happens. Some people can be put on end of life and later they will remove it. Some people will even start receiving all these injections and medications that they will still survive. So, I mean, okay. Right. So, we are discharging patient, medication teaching. Is it gone? Okay. The medication the patient is going to take, the name, the purpose, the dosage, the side effect, everything. Are they getting it? Then after you've done the medication is very, very important. So always teachings. You use what we call the teach back method. Okay. Ask the patient to explain the instructions in their own words before you allow them to go home. Okay. But you see, one thing about case management, all these things case managers were supposed to do, but we do it, the nurses do it for them. So they just chill. Okay. Yeah, because I don't remember the last time I even I allowed any case manager to teach the chart teachings for my patients. You do it. I mean, so wound care education. Yes, patient has a wound going home. Discharge dressings or dressing changes are often any sign of infection, hand hygiene, follow-up care, and all this one. Arrange follow-up care. Okay, so all these people will be contacted. The primary care visits, specialist appointments, physical therapies, home health services, laboratory testing in the house. Okay, then you provide written instructions. So you talk to the doctor. They should be given a written instructions paper. Okay, that then you the nurse you highlight this place, take this medication, so and so, go and collect this medication at this pharmacy. Call your GP practice or your doctor or your clinic and book a follow-up appointment on so and so. You highlight it for them on that paper with a highlighter, or you can make an asterisk, the key points. Then they take it home. Yes. So now patient is home. He has gone to home care. Victor's company has sent people into the patient's home. Okay. Why? Because the patient still needs nursing care, but his condition has been stable that he does not require hospital admission. Okay. So what is the benefits this patient is going to get from Victor's company, the home care company? Okay. So patients who benefit from home care are what? Older adults, stroke survivors, heart failure patients, post-operative patients, patients with chronic illness, and patients requiring wound care. Okay, home care. So Victor's company will come and help patients to take medications, wound care, IV therapies, physical therapies, occupational therapy, speech therapies, health education, chronic disease monitoring, all these things, and they document and send their report for quality control. Okay, so that their license will be renewed when it expires. Okay, yes, Victor will employ nurses. So the nurses will go and assess the home environment. You say you don't want to go to care home. Okay, you want to go to your house so that health workers will come and take care of you in the house as home care. Let's go. I want to go and see your house. So people will come and inspect your house, assess the home environment. When we came, we realized that when we enter your house, it is only the hall that is down floor. All the bedrooms are upstairs. Meanwhile, you are a wheelchair patient. How can you walk on this staircase to the upstairs? Are you going to sleep at the hall? No, we will not allow you. Okay, we won't allow you. So we will now make another plan for you. We will not allow you to go. Otherwise, when you go, it's either you sleep at the hall or you try climbing the staircase and you fall down and you come back to the hospital, which we don't want it that way. So we evaluate safety hazards, reinforce medication adherence, monitor disease progression, teach caregivers, and prevent falls and injuries. Okay, yes. Let's come back to Tichubu, case manager. So there is a patient who has come to the hospital who needs rehab. So Tichubu will call the rehab facility. Okay. Then they will ask, which patient are you bringing? I'm bringing a patient that I want you to help him or her to regain their highest level of physical, emotional, social, and vocational function after an illness or injury. Rehabilitation. Okay. Then say, okay, bring him. So the goal is to what? Help the patient restore their independence. Somebody has been capitalized, or is an abuser of drugs. The least money he gets, you go and buy drugs. This guy does not have freedom. So we want to help him to be restored. Okay. Yes. Improve mobility. Improve communication. Rehab is, see, everybody can go to rehab. Okay. Improve quality of life. Somebody is worrying you in the house. You are having psychological anxiety issues. Rehab to go and come back to yourself. Prevent disability. Okay. So the rehab guys will come in. Somebody has got stroke. Somebody has got this. We take them to rehab and all this. So stroke, spinal cord injuries, hip replacement, traumatic brain injury, amputation, orthopedic injuries, neurological disorders. So when you go to rehab, you see all these guys, physiotherapists, nurse. So when you pass your NCLEX, some of the agencies will take you to rehab units. Okay, so that is what, it's not a hospital unit. Okay, so as a nurse working in the rehab unit, what is your duty? You are the custodian of the patient. So you encourage patients' independence. You reinforce therapy goals, prevent complications, educate patient and family, and provide emotional care. Okay. Somebody needs palliative care. Tichubu, we need you again. Okay. So Tichubu will call the palliative team or palliative facility. That's palliative care is a specialized medical care that focuses on improving quality of life of patients with serious illnesses by preventing and relieving pain, symptoms, and emotional distress. So palliative care, remember, It begins at any stage of a serious illness. Somebody has gotten, HIV or cancer, tuberculosis, all these serious illnesses from day one till the day they will die. They can receive palliative care. Okay. But when from day one they got the disease till the time they die, that phase is we call palliative care. The phase of your serious illness. Okay. Yes. But once you start and you are deteriorating, you get to a stage that everybody sees that, oh, you are dying. They will declare you end EOL of life. So from the end of life to the day you die, you will now start receiving what we call hospice care. So over here, your comfort is the most important thing. Comfort care. Some people call it comfort care. Nursing to a peaceful death. In Ghana, that's how they say it. Okay. Yes. So inside palliative care, you find what hospice care. That's it. It can be provided alongside curative treatment and all those stuffs. Okay. So the goal of palliative is what? Pain management, symptom control, emotional support, spiritual care, family support. Somebody has been brought to the unit. The Chibu has sent his cancer patients to your unit, palliative unit. Okay. The goal, the reason why he brought the patient there is to receive all these things from you, the nurse. So, what are you going to manage as a nurse? The pain, the shortness of breath, the nausea, the fatigue, the anxiety, the depression you are going to do. Now you've done everything, patient is not surviving. So we switch to what? Hospice care. So we put patient to what? Hospice. These are given to patients who are nearing the end of life and are no longer receiving curative treatment. So mostly these people's life expectancy is about 6 months or less. So doctor will say you have 6 months to live. With this your condition, you have 3 months to live. Okay. Determined by the healthcare provider. So in Ghana, they will say doctor declare. Okay. So when doctor declares you, so what of if the patient's family cannot pay for the hospice care? Yeah, somebody is asking if the patient's family cannot pay for the hospice care. You take the patient to the hospital. Okay. Take the patient to the hospital. The message unit, sometimes they use some of their rooms for those things. Okay. Yeah. So hospice, comfort is our goal. Comfort, nursing, healthcare assistance. You are going to take care of this patient. He is dying. The comfort of the patient. It's not about you're going to move the patient, move up and down. No. You are causing stress. Okay. We give medication. Say they are having secretions. We give all these medications to dry their secretions. Okay. They are having pain. You give them morphine and all those stuffs. Oral morph to cure the pain. Okay. Yes. Emotionally, they are having their family, spiritual life, peaceful end of life care. That is hospice. Okay. Yes. Then the pain management, nursing care, counseling, and bereavement system services. Okay. So common locations, some even do home. That we want to do hospice in our home. Okay. Yeah. So when I was in UK, when somebody is about to die, the family all will come to the care home. Okay. And they will come and stay with the patient till the patient dies before they go home. Some too say that no, we can't come. You nurses, you everything, whatever. When he dies, just notify us, and we will know that he's dead. Then they will tell you when he dies, this is the mortuary, or this is the funeral director who wants to. We want you to tell them to come for the body. They will do everything. So the funeral directors in abroad, funeral directors do funeral. So the funeral directors will plan. They plan the funeral, everything. Then it's not about you are going to do posters, you are going to do this. No. Funeral directors will plan everything, and they will do the funeral for the patient. Okay, yes. So, so some people can choose. We want to go to hospice facility. Some will say we want to do nursing home, hospice. Some will say hospital, especially med-surg units. Okay, so a patient, you went to work as a med-surg nurse, and they told you one of your patients is on hospice. You should be ready for anything on the shift. Yeah, we have funeral directors. So this is the comparability, the differences. Those of you who doesn't know, okay, this is it when you get the slide. Then discharge. So under discharge planning start on admission. Always use the teach back method. Home health is appropriate for patients needing skilled nursing, but not hospitalization. Rehabilitation aims to prioritize independence. Palliative care can be provided with curative treatment, and hospice care focuses on comfort when curative treatment is no longer the goal. Case managers coordinate services across healthcare settings to ensure continuity of care. So I don't think the Chubu should get any answer wrong with case management or nursing care. Okay, so let's answer these questions. A nurse is preparing a patient with heart failure for discharge. Which action best promotes continuity of care? These are the actions. Yes. Yes, shoot your answers.
So I was thinking of B, begin discharge planning and admission, and arrange follow-up
Yeah.
appointments.
Good.
So I'm also going for
Mhm.
B.
B. Okay, good. Right. Number
Yes.
2. Which patient is best candidate for home health care? Yes, case manager or nurse as a manager of care.
The
Which of these patients will you take to home health care?
I was thinking of a healthy adult client for recovering from minor cold.
Minor cold.
Yes,
Yes. Cricket is yeah. Cricket is yes.
Me,
I'll
I'm
go
going
for
for
B.
B.
A feeling
B.
skilled wound
Yeah.
care.
B.
Yes.
Correcte
Yes,
soya.
B.
Correcte
Yes,
soya.
B. Yeah. Number
Eh,
3.
So
Let's
why not
shoot.
D?
Yes, B. Yes, B. A
Why
patient
not?
who needs daily skilled wound care after hospitalized discharge.
Okay.
Okay. So
All right.
Victor's company will go to the patient's home to help.
Okay.
A
Thank you.
minor cold
Sini
is
obi a ɔma
infection.
no code bebree. Sɛ nka ɔnyɛ yi saa o. A wɔyɛ health nso deɛ nka ɔnyɛ obi a
Yes, you will not go and contact Victor's company to send health workers to go to the patient's house to help him manage minor cold. It doesn't work. Please, do you understand?
Yes, I get it. I get it.
Good. Yes. So, number 3, which statement correctly distinguish hospice care from palliative care?
So palliative care may be given while curative treatment continues, whereas hospice care focuses on comfort when curative treatment is no longer the goal. The C.
Perfect. Okay. So we are getting to the close of our seminar, this week's seminar. So on model 17, we are looking at interdisciplinary committee collaboration. Okay. That interdisciplinary, all the disciplines of healthcare workers. How we should talk among ourselves, how we should give reports, okay, how we should work together, teamwork. Okay, so what are the various ways we can use? Okay, so we will know the purpose of this team, the reason why we need to collaborate with other health workers. We will know the purpose of SBAR. Okay, we will describe the principles of the team steps, and we will perform safe and effective handoff reports. Okay, then we recognize the steps or the characteristics of effective interprofessional teamwork. Okay, perfect. So let's finish this quick, then we are done for the day. Interdisciplinary collaboration is the process of healthcare professionals from different disciplines working together to provide safe, effective, and patient-centered care. So why do we have to collaborate? What is the goal? What is the aim? To improve patient safety, to reduce medical error. Okay. The doctor has given a patient medication. The nurse does not know. The doctor must tell the nurse that I have given this patient medication, so please don't go and give him another medication. It is a collaboration. Improve communication, increase patient satisfaction, and promote quality care, and also improve healthcare outcomes. Okay, so who are the members of this interdisciplinary team? We have all these guys. I couldn't list. So if your profession is not part, forgive me. Okay. Yes, all these health workers, when you go to hospital, you meet them. The chaplain, case manager, social worker, dietitian, and all this. So let's look at the way they talk, communication. You should talk the best two, which everybody knows is SBAR. You are talking to your colleague nurse or your doctor about what? A patient, always use the communication tool SBAR. So you know SBAR. I've told you SBAR, situation, background, assessment, and recommendation. It helps to reduce communication errors during provider calls, emergencies, and handover or handoff reports. Okay. So situation, you look at the patient situation, who you are. Tichubu mentioned his name. Please, this is Tichubu working on message so and so on this unit. The patient's name, okay. The patient's name is, he mentioned my name, Paul, patient Paul. The current problem the patient is having, the current situation. So, hello, Dr. Smith. This is Paul Aaron on the medical unit. I am calling about Mr. Johnson, who is experiencing chest pain. So once you make this statement, if I am the doctor, I know the problem the patient is having currently, experiencing. Okay, good. Now let's look at the B, the background. What brought the patient to the hospital? And when he came to the hospital, what was his comorbidity of the previous medical history? That's the background. Okay, we are not talking about tribe. I don't need tribe in medical reports or a handover. Okay. So the background of the patient, the diagnosis, the admission reason, the medical, the allergies, the recent treatment, vital signs, laboratory results. So he was admitted yesterday with pneumonia and has a history of coronary artery disease. I've given you a short background. Okay. Now, assessment. If you have told me the current situation and you've told me the background, no nurse should skip assessment. You're going to talk to a doctor. You've not assessed the patient. You just pick phone and called. Have you checked vital signs? Doctor, can you wait? Let me quickly check the vital sign and come back. Some doctor who doesn't have patient will insult you and cut the call on you. Okay, because you don't know what you are doing. So assess and get your information. You did your assessment. This is the result you saw. Then you call the doctor. Okay, yes. So describe your assessment. You check your vital signs. You got these ones. Your oxygen saturation is this. And patient is pale and diaphoretic. Okay. Now make a suggestion. The nurse should always make a suggestion. What you think should be done. There are some doctors, they will think, okay, so what do you think we should do for this patient? If you don't say it, they will rather ask you, what do you think we should do for this patient? Okay. Then you say, doctor, tell the doctor what you need. That is the recommendation. Otherwise, we will not teach nurses physiology. Okay. The nurse must know what the patients need. So evaluate the patient immediately. Request additional laboratory tests. Request new medication orders. Request transfer to ICU. Okay. Let me give a scenario. So my patient has sudden shortness of breath, admitted for heart failure yesterday. Oxygen saturation dropped to 82 despite oxygen therapy. I recommend you assess the patient immediately and consider additional interventions. Okay, let me give you another scenario. You are an RN, you went to church on Sunday. Whilst you were doing praises, okay, one patient who is, everybody knows in the church as epileptic. Okay, everybody knows because it has been happening. And now the patient collapsed, and luckily the church has a small first aid box. So you did a quick assessment and you realize that the patient saturation is what? 86. Okay. Then you also, when he collapsed, he had seizures. Yes, epilepsy. But it is recurring seizures. Okay. You are not supposed to put this patient in somebody's private car. The hospital, it is not a good practice because in that private car there is no oxygen. Okay, you were RN in the church, you called 911 ambulance. How will you do your S-bar? Who will try? You went to church on Sunday, epileptic patient has collapsed, is having seizures. Seizure is not stopping. Oxygen saturation is 86. Yes, call ambulance. Talk to the ambulance personnel. Sharp.
Sir, I want to get
Who
more
will try?
information on the client, sir. So this client, I do not know him from anywhere, or do I know something about him?
No. You don't. You also are also a church member. You went to church, but in the church, everybody knows that this guy is epileptic. He has been it has been occurring, but this
Okay.
time around, the seizure is not stopping.
Okay. So let me
Okay.
try see. Okay.
After
Okay.
you, if you will talk. Yes.
Okay. So I've called. They've answered. Hello, my name is Nicholas. I'm calling from the Church of Pentecost at New Louisiana.
Okay.
I'm calling because of a no. Yeah, I'm calling. Okay. So I'm okay, I'm calling to report
I
the
think I'll give
situation.
you easy
Okay.
questions.
No, sir, let me try. So I don't know whether I should say, okay, well, I'm reporting. So I'm calling to report an incident right now. Mr. So what name should I? Okay, Mr. Paul. No, let me use Bright. Mr. Bright, a known epileptic patient, is currently having a seizure that is lasting about 5 minutes. Please, you said?
Mr. Bright.
Oh no, Bright is not his name. Oh.
It's my name.
That is
You
his
don't know I'm
patient.
calling.
Sorry. Okay, so sorry. Okay, so let me use Samuel. So I'm calling.
Okay.
Sorry, sir. So I'm calling to report an incident happening right now. Mr. Samuel, a known epileptic patient, is currently having a seizure and an attack, which is lasting for over 5 minutes. He currently has a SpO2 saturation of 86%, and apparently he has no apparently, sorry. He was admitted yesterday at the hospital, and but you are saying admitted yesterday. I should forget about what the background you are giving
I
here.
didn't mention any admission.
Oh,
You
okay, all
went
right.
to church. Everybody in the church
Okay,
knows
all right.
he's
Okay,
epileptic.
okay, all
Uh-huh.
right. So let me start over again. They've answered. Hello, my name is Nicholas. I'm calling from Church of Pentecost at New Louisiana. I'm calling to report an incident happening right now. Mr. Samuel, a known epileptic, is currently having a seizure, and on assessment, he has an SpO2 of 86%, and he currently is seizing. I'll recommend you call an ambulance right now because his situation is serious, is deteriorating. And I also recommend you fast track calls to nearest hospitals or clinics available to attend to him urgently. Thank you.
Okay, good. Another person, if your hand is up. Yes.
Okay, for me, I'll call the ambulance first.
Okay.
In a situation, I'll call the ambulance.
Yes,
But
they are the 911.
yes, when I call, before calling, I would be fast to ask questions, and maybe that's my first time getting to know that he's an epileptic. I'll call, after calling, I'll just tell them about that there's a patient, like there's someone who just had epileptic seizures, and that the saturation is 86. But I would let them know that the patient is already an epileptic due to what I asked at the I said hospital, the church. And after that, I would make sure that I will loosen patient's clothing. I will do that. If it's tight, I will try to loosen. Then safety too, I'll make sure that he is at a place that is not really crowded too. I will do all that. Then probably I will still be waiting for the ambulance people, since I've said what I'm supposed to tell them. Then aside that, I will make sure that there is not going to be restraint, but the person is still in seizure, so maybe they'll be forming, so I can tell the head some another side. I think that is the only thing I can do.
Another person, see, if you did something, you are the situation has happened. You don't have any equipment on you. You are calling for emergency response. But bear in mind that you are a nurse, and those people too are health workers, interdisciplinary communication. So you are using S-bar to talk to them that this is the situation I've come to meet. Which you said, you said it right. Yeah, you mentioned that patient is having seizures. I mean, when you asked the church member, they said the background says it is something that is already on him. Okay. Yes. And you said you also mentioned your assessment that the SpO2 is 86, but you did not recommend to them what they should do. And you started treating the patient. You understand? Yeah, so that is it. That is it. Yes, Nico.
Is it necessary to ask for ETA, estimated time of arrival?
Yes, you can.
Okay.
You can.
So, okay. Just to
and
alleviate. Okay.
it's not even you can. You should ask. Estimated time of arrival. Yes. Anytime you speak to patient transport or ambulance services, ask them. Okay, your hospital is not a pediatric hospital. You are transferring a pediatric patient who came to your ER to a pediatric hospital. Yes, you call the ambulance. They should tell you what time are they coming, like estimated time of arrival. All these ones. Okay. Let's look at another method to communicate within health workers. We call it the team steps.
Hello, sir.
This is a tool.
Hello, sir.
Team steps. Yes.
Sir, at the church, how was she able to check for the SpO2 since she was not having any equipment there?
I mentioned that the church has a small first aid box.
Small first aid box.
Okay, thank you, sir.
So you use yes. I'm examiner. Right. So another way to communicate, I'm showing you so that you choose the one that is best for you. You call it the team steps. So it's an acronym. Team strategies and tools to enhance performance and patient safety. So it is an evidence-based teamwork system that improves communication and patient safety. Okay. So what are the principles guiding team steps? A leader. Yes, we are communicating. So it ensures leaderships. So before we assign you as a leader of this team, okay, the leadership you should be very effective. Okay, so the leader should assign the roles, set priorities, monitor progress, and encourage teamwork. That's it. Then when we come, we are also looking at the situation. Okay, the patient status, the environment the patient is it safe? The team performance and available resources. Okay, then the mutual support. Healthcare team members, we assist each other, provide constructive feedback or criticisms, speak about safety concerns, and request help when we need it. So people in a ward nurses, they use the team steps to work on the ward. We go to work, one of us will be a team leader. You assign the roles to us. We help each other through mutual support. Okay. Then communication, when we are communicating to each other on the shift, it should be clear, concise, accurate, and timely. Okay. So what are the communication tools team steps mostly use? After knowing all these principles, what tools are we going to use? One, we have the call out. Okay. When do we use call out on the ward? During emergency. So when we ring the call out, rapid response, emergency, everybody, whether you went for your break whether you went to the park, where some factories also use call outs. When they ring the alarm, wherever you are, you will hear. Then you come. So somebody's blood pressure is crashing. Okay. Everybody immediately hears the critical information, the alarm. Then we come, emergency response. Let us come and help this patient to survive. Okay. Yes. Then another tool that we can use in team on the ward. We were talking. Oh, Tichubu called. Please, can you help me with cannula? Okay. He is working on the patient. Then he shout, can you help me with cannula? Then somebody is ready to give patient a cannula. Then the person will verify, okay, that which type do you want? Or did you say cannula? It is used to verify information. Example, the nurse will shout, give 2 milligram morphine IV. The student nurse or the second nurse will say, did you say 2 milligram IV morphine? Then the first nurse has to respond, okay, yes or correct. Yes. Then a huddle, the same word. We have something we call huddle. Some people will choose huddle or huddle, wherever is a noun, anyhow you want to say huddle. Some people will do huddle at the beginning of the shift. So we are a team. Boys, the Kuyamwa, Tichubu, we are all nursing on the Ayariga is our charge nurse for the shift on message. So the charge nurse will come to work early, 1 hour early. Most of the hospitals in US, that's what they do. Charge nurse will come 1 hour early before the team comes. So he will come and take report, handover for all the patients, and make the plan for the shift for the next 12 hours for the team come. That's all his assignments. This patient will go to this patient will go. So when the other team comes after the 1 hour, he will have a short meeting with all of us and discuss the situation within the last 12 hours. This is what happened. These are the care plans that was reviewed. These are the problems that was caused, and these were the solutions. Okay, this patient, you had this patient yesterday. Please, can I give you to this patient reassignment? Then you also, this patient yesterday when we came, he did not sleep all night, but during the day they said he slept all day. So please, if you are going to give this patient any sleeping medication, omit it or do this or do that. We call the doctor, and so we call it team huddle. Some people too will not do huddle at the beginning of the shift, but when the shift is ongoing, especially day staff, when the shift is ongoing, they will now call each other, all the team members. Then we will do a short briefing on how is the shift going. Can you tell us about your patient? Do you have any challenge? Do you have this? Then blah, 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 sharp. Everybody. Then we also use on the shift, we also use something we call debriefing. So we use debrief when some major incidents has occurred and all of us came together to help solve the incidents. Somebody has had cardiac arrest. We all stopped whatever we were doing. We came to you to help revive the patient, whether he survived or he didn't. We do debriefing. Okay, so when we were working on the patient, what happened? You spoke to me, I wasn't happy with it. Okay, debrief. We were supposed to give adrenaline at so and so time, but it was delayed. Okay, you were supposed to do effective CPR, but you couldn't do it well. So you review what happened, identify improvement, then you learn from it. That next time we are not going to do that again. So that is called debriefing. So all these ones forms under our team steps. Yes. So nurse managers can use these strategies also to communicate within themselves on the ward. And it's very good when you go to work and you do this team steps. It's very good, especially you and your colleagues. Okay. Then handoff. It is time for us to go home. Or a patient is coming from a new unit to your unit. Or you are transferring the patient to a different facility. We call it handover. But here they call it handoff report. Some will say handoff. Some will say report. They are all the same thing. Okay. The transfer of a patient information and responsibility from one caregiver to another. So nurses will do their handoff. Healthcare assistants will do their handoff. Physiotherapists will do, all the health team will do their between themselves. Okay, so a shift change. When do we do handoff? Shift is changing. People are closing, new staff are coming. We are transferring a patient from the ward to ICU or ICU to the ward. We are transferring from the OR to the PAC, okay, PACU to the ward, or ED to inpatient, inpatient to ICU or PCU. Okay, the goal, why do we have to do handover? To ensure continuity of care. And remember, you are learning management in nursing, so you should ensure that this handoff and all these things we have learned, they do it. Okay, prevent communication errors and improve patient safety. So effective handover includes patient identification, diagnosis, allergies and co-status, and all these stuffs. Okay, yeah. Then bedside. Some people can do bedside, some people can do telephone handoff. Okay, but the best, which all nurse managers encourage, is what? Bedside handover or handoff. All nurse managers encourage bedside handover. What are the advantages? Sometimes it even allows the patient to also participate in the handover. They can talk, okay, about it. It increases accuracy. It gives opportunities for questions and answers, and it improves safety. And also it improves verification for IV lines, drains, and other equipment. Patient is on this drip, is running at this rate, and this volume is left. Patient has an IV line on the left antecubital or right antecubital, or patient is having a central line with double lumen or triple lumen. Patient is having a port, patient is having this, patient is having a surgical drain, patient is having a catheter, or what. So you verify all these ones. Patient is receiving TPN. We are doing everything at the bedside. So sharp. Okay. Some of the errors we see, some of the errors we see with handover is missing allergies, incorrect medication, incomplete communication and assessment, failure to communicate abnormal findings, omit code status, and interrupt during reports. So when you miss all some of this information, we call it what? Error in what? Handover. Okay. Now, interprofessional teamwork. Different health professionals from different disciplines collaborate respectfully to achieve the best outcomes for the patient. Okay. Yes, we need to collaborate in a trustful manner, respectful manner. We share our goals, open communication, accountability, collaboration, and mutual. So you, the nurse or the nurse manager, what is your role? You communicate with other health workers well, clearly. You always advocate. The patient is yours. Other health workers are visitors. So always advocate for the patient. They are coming to take the patient to a CT scan. The patient is claustrophobic. Will you allow them to take the patient there? No. Okay. You should advocate, collaborate with all team members, report changes promptly, participate in care planning, and respect each discipline's expertise. That is the necessary role. So always speak up for the patient's safety. You speak up immediately, not later, and notify the appropriate provider. Okay, yes. So this is what patient safety always comes first. So do you want to use handoff or you want to use S-bar? The decision is yours. You have learned this training. So you will decide which one to use. Okay. And these are the differences that comes with it. If you want to go normal handoff, you should take note of all these things. Okay. But S bar, quick, sharp, you are done. You are gone. Patient came with this problem. Currently he's having this. We've done this and that for him. Okay. So your recommendation to the nurse who is coming, but we go. And these are the pearls. So we've done S bar, we've done check back, we've done callbacks, we've done hurdles, we've done debriefing, then we've done bedside and effective team management. So let us answer these questions. Then we say goodbye for today. Okay. And next course. A healthcare provider using SBAR. Which information should the nurse provide during the assessment portion?
B.
Yes.
The patient
B?
is short of breath. Yeah.
Okay, good. Shortness of breath with an oxygen saturation of 84. Right. Question number 2. Which team steps communication tool is used to verify that verbal information was heard correctly? Yes, team step. You are working on the word. Did you book call? Please, I need
Check back.
IV cannula.
Check back.
See, check back.
Check back. Good. Right. Number 3. And that's the last question. Which information is the highest priority to include during a handoff report?
The patient's code status, allergies, current assessment,
C.
and pending tests.
That's the C.
On this note, I say goodbye. Okay. Thank you so much. Please remember, when you get a slide, you click on this link and you like our channel on YouTube. Let us grow the channel so that people, you can sit at home. You don't always have to join the Zoom. You can watch it from YouTube, because whilst we are doing this, it is streaming live on YouTube and Facebook. Okay. Yeah. So go and subscribe to the channel. And you can also, the videos as it's streaming, is also recording there. So the videos are all there, the YouTube channel, so that anytime we drop a video, you'll be notified. Then you can watch it and learn. Okay. Share with your colleagues. Okay. So that they will also know. So thank you so much. Let me stop the share. And next week, we'll do our psychiatry. Next week, we'll do our psychiatry.
Thank you
Tomorrow
so much, sir. God bless you.
Tomorrow is questions. So I don't know if Ayariga has time. You can take over questions tomorrow. So tomorrow, pure questions on management of care, recognizing cues. We've done a lot. You know how to recognize cues. You know how to analyze cues. You know how to triage. You know, okay. The same time.
Sir,